Good morning, everyone, and welcome to Semel Grand Rounds. Today we have Dr. Jonathan Comer, who's joining us from Florida to talk with us about using technology to expand the reach of our care, which I think is something we can all agree will be timely in light of current events. If you have any questions for Dr. Comer, you can use the Q&A button to submit it at any time. Also, please remember to check your email after the presentation ends to fill out a survey for CME credit. And now, Dr. Tara Paris will introduce the morning speaker.
Good morning, everyone. It's my pleasure to introduce today's speaker, Dr. John Comer. Dr. Comer is a professor of psychology and psychiatry at Florida International University, where he directs the Mental Health Interventions and Technology Program, or MINT, an interdisciplinary research program devoted to expanding the quality, scope, and accessibility of healthcare for children and adolescents. We're really fortunate to have Dr. Comer with us today as his research focuses on topics that are particularly timely and clinically relevant for us. In particular, his work evaluates the use of new technologies in mental health care, including things like video conferencing, mobile platforms, and passive sensors. His research also studies the well-being and adjustment of children and families following disasters, terrorism, and community traumas. And he has led several large-scale surveys following adjustment and outcomes for events such as 9/11, the Boston Marathon bombings, Hurricane Irma, and our current pandemic. Dr. Comer has over 180 publications, including a textbook on abnormal psychology. He is the immediate past president of the Society of Clinical Psychology and the incoming editor-in-chief of the journal Behavior Therapy. He has won a slew of early and mid-career awards, and we're very fortunate to have him with us today as he talks about how we can leverage technology to improve mental health care for children and adolescents. So I hope you will join me in giving him a warm welcome virtually.
Well, thank you so much, Tara. I really appreciate your kind introduction. I'm right now going to share my screen. Well, thank you so much for that kind introduction. You know, these Zoom Grand Rounds are great, but when they're at places like UCLA, where I have so many friends and former, I remember driving to grad school every day with Patty Walshall. So many friends, Tara, I really wish I could visit in person, but I promise if you have me back after this pandemic, I'll give a whole other talk with completely other data. As was said, I'm going to speak today about moving beyond brick and mortar, moving outside of office-based care and leveraging technology to expand the reach and the scope of mental health care. I want to first some disclosures. I earn publishing royalties from Worth Macmillan for textbooks and some of the grant funding that made this work possible. And then certainly I want to thank my team, the Mental Health Interventions and Technology team. You might see some familiar names, Danielle Cornacchio, who we miss very much. I know she's with you right now. She was one of the fantastic members of our team and contributed so much, and in fact led a lot of the work that I'm going to be speaking about here today. I'm going to be speaking primarily about children's mental health care, but almost everything I speak about is going to be relevant across the lifespan, working with adults and older adults as well. Usually when I give talks, this is about the time when I'll speak about how, about the tremendous burden and impairment associated with mental health problems in kids. When left untreated, they're stable and chronic and then result in tremendous impairments and reduced quality of life. But given that I'm speaking to the UCLA Department of Psychiatry, this slide feels more relevant. Feels like I don't need to spend too much time going into that. The good news is over the past 40 years, and in particular the past 20 years, the field as a whole has made tremendous progress in developing supported programs for the vast majority of mental health problems that children present with. And these programs vary, and they're, we have just a small sample of them here. The bad news is we're not reaching kids with these programs. So obviously at departments like UCLA, children have access to wonderful quality care, but the majority of kids in need are not receiving any mental health care, let alone quality mental health care. We have a number of crises right now, professional crises. We have, of course, the unacceptable and widening disparities in care. So quality care tends to cluster around major metropolitan regions or academic hubs, and particularly underserved are communities that are rural communities, low-income communities, and ethnic and racial minority populations. And we have this terrible person power imbalance in the mental health workforce. Alan Kasdan has estimated that if you were to even double the number of mental health providers available, we still wouldn't even make a meaningful public health dent in addressing mental health needs. That's how underserved we are. There's also stigma-related concerns. Families often report that they don't want to go to a mental health facility to get support for their family. Transportation barriers, of course, even if maybe there's a quality mental health clinic 20 minutes away, if there's no transportation options, then that's another significant barrier. And then among the small proportion of families, children and families who do access care, we see long wait lists at underfunded clinics, outcome gaps, so children aren't showing the same outcomes that we see in tightly controlled research trials, and then poor maintenance and generalizability of gains when people are receiving short-term treatment at these facilities. And this was all before the current global pandemic. So this was before stay-at-home orders and guidelines efforts to mitigate the spread of COVID. So now more than ever, these are problems. It's important to sort of think back on our model of treatment. The predominant prevailing model since the beginning of psychotherapy has been office-based care. Certainly for outpatient care, clinic-based care. People leave their house, come to the clinic, and meet with the therapist where the therapist is located. And we've seen great outcomes when we can get people to the clinics and we can implement treatment in highly supervised scenarios. But that's not where kids are. Kids don't naturally present to mental health clinics. There's a famous bank robber, Willie Sutton, who famously, when a reporter supposedly asked him, "Why do you rob banks?" and he said, "Because that's where the money is." According to Snopes, maybe he didn't say that, but he's famously credited for that, so I'll go with that. So he said, "Why do you rob banks?" His answer was, "Because that's where the money is." So if Willie Sutton was a mental health provider, he would be treating people in their natural settings. He wouldn't be treating people in mental health clinics because that's not where people naturally congregate. So we need to be thinking about delivering care in more non-traditional settings. These icons here are just some, homes, schools, the workplace, primary care. This last one's supposed to be sports and recreation. It looks like someone's, like an icon. All my students tell me it looks like someone's bowling. I'm not sure if we want to do mental health care in bowling alleys, but the point is reaching people where they naturally are. The internet, of course, as you know, makes this much more achievable than in years past. The first idea of a remote doctor, this is not even in psychiatry, but in just all of medicine, there was this sort of science fiction publication called Radio News, sort of like a Jules Verne publication. 1924, the magazine had a special issue of Radio News that actually predicted telemedicine, and the issue referred to what was called at the time the radio doctor, and the doctor had this weird contraption that never quite made sense. It had something to do with microwaves. Those were called a teledactyl, which I think means far-reaching arms. But somehow, through technology, this science fiction magazine envisioned that doctors would be able to provide remote care to families in their setting. In the 1950s, we're always seeing technology being incorporated into mental health practices. In the 50s, when affordable household telephones were available, we saw the emergence of the first suicide prevention crisis hotlines. We saw in 1973, the term telepsychiatry was first used in the literature. This was at Mass General in Boston. People would fly in to the airport in Boston to receive world-class psychiatry care from a provider at Mass General. But there's a lot of traffic in Boston, and the idea was there was a suite at the airport where people would land. They'd go to the medical suite at the airport, and then through television signals and two-way video, they received routine care consultation. So here we were talking about not just a demonstration, this is the first telepsychiatry service. So there's always, going back, even to the 70s, there's been scholarly interest in remote treatment through technology. But we saw really this uptake. This is a sort of a meta-analysis my group's been working on, tracking across time research publications that are examining technology for the remote delivery of mental health care. And you see around 2005 is where you see the sharp uptick, this escalation. And of course, around then is when we saw household internet really blossom. And so right now, there's always been these issues of a digital divide. The internet is not accessible to everyone. Right now, we're at a much better place. We still have a ways to go, but right now, 89% of adults use the internet regularly, and it's a little bit higher now. These data are 1 year old, and the digital divides are even disappearing. So we no longer see a digital divide by race and ethnicity. You can see in that top left graph, it's all been converging. You do see some digital divides remaining with regards to rural versus urban and suburban. So urban and suburban, you see almost ubiquitous access to the internet. Whereas only about 80% of families in rural communities have readily accessing the internet. And you also have some digital divides where families making more than $30,000 a year have near ubiquitous internet access, but with 30,000 and below for household income, you're seeing only about 81% of families. And then of course, the internet access is not unlimited the way that you see internet access in higher income households. So we have a ways to go, but the digital divides are disappearing. And in light of the pandemic, there are many new initiatives to increase widespread access to the internet. The digital divide by age, we're seeing among young people, families 50 years and under, we're seeing 96% of adults age 49 or under. So some of these digital divides are aging out regardless of income, which is positive news, very promising for using technology to expand the reach of care. And then it's also important to talk about how people are accessing the internet. And this has really changed across time. It used to be that we were talking about mainframes, then personal computers, desktop computers. Now the majority of internet access is on mobile devices, and we're moving more toward wearable connectivity, where people are wearing the internet as bracelets, wristbands, even contact lenses are where things are headed. This is a picture of my daughter from, I think, 5 or 6 years ago. We were at an airport, and she saw this, and she said, "What's this?" And I said, "Oh, it's a phone." And she said, "Well, where does it play the movies?" So this sort of goes to show how technology is evolving and how people are accessing the internet is dramatically changing. When you look at what people are doing online, what they admit to, the third most common thing they admit to doing online is looking for health or medical information. So this is where people are naturally presenting when they have a health problem. When I have some spot on my arm, I don't call my doctor. I look it up in Google. It turns out it's always cancer. And you go down that rabbit hole. But whether the information is good or not, this is where families are naturally presenting as the first stop when they have questions or concerns about health and medical info. And this also goes for parenting information as well. So the idea of technology, really, there's two main promises or potential that we're talking about. One is that there's an opportunity to overcome traditional barriers to care. So we can reach families in rural areas. We can reach people regardless of their geographic proximity to quality mental health care. We can deliver care directly in their home. And then there's the second potential of telehealth, which is to expand the ecological validity of treatment by treating patients in their natural settings. So We know that it's one thing to work with a family and teach them better ways to communicate. It's another thing to be able to live coach them at the dinner table. And so by providing treatment in the very settings in which problems are most significant and relevant, we see there's a potential that telehealth affords more options for quality care. Another example is in exposure therapy for anxiety, OCD treatment. It's a very effective model, but not very broadly scalable, is home visits. People, when I work with kids with OCD and they have a specific tapping ritual with their toothbrush on the soap dish a couple times, and maybe they have to shuffle their feet a certain way when moving from one room to the next. It's one thing to simulate it in my office, but it's another thing to be able to provide that treatment directly in the home. So technology potentially expands the ecological validity of care also. So when we think about how innovators have been applying technology, it used to be that people would say, oh, well, these are mobile apps, and then these are computer-based apps, but everything's cross-platform now, and there's no longer much value in thinking about the devices things are used on. It's more useful to divide things up and think about what the role of the therapist, the human therapist. So you can see there's sort of our group clumps these into three boxes. There's full therapist involvement. That would be like video conferencing treatment where the therapist is involved entirely in the treatment. That's technologies being used to provide real-time synchronous treatment. There's standalone, no therapist. That's maybe an app on the phone where you don't have you don't have any contact with the therapist. And then there's minimal therapist involvement, which is sort of a bit of a hybrid where you're doing a lot of asynchronous, not in real time work. At the same time, you're through maybe a mobile device or an app. And then you have brief check-ins, which we can talk about a little bit. So first, I want to talk about full therapist involvement. One, because this is where I've done most of my clinical trials, and also because this is where we're seeing the most positive outcomes, the most evidence of support. So telemedicine, here with telemedicine, we're talking about the use of electronic media to facilitate real-time interactions for the provision of care that's usually delivered in person. So we're talking about real-time treatment. Typically, it's video conferencing, where you have audio and video, and you're interacting in real time synchronously, as some people refer to it, with your provider. When we're talking about video conferencing mental health care, this is one of the issues in the literature is there hasn't been much consensus around terms of use. Some have called it behavioral telehealth. Some call it telepsychiatry. The psychology folks don't like calling it telepsychiatry. And the literature really has, I think in the last year or two, increasingly adopted the term telemental health, which covers psychiatry, but also other types of mental health treatment and support. And I think casually and anecdotally in the literature or in the mainstream, people are calling this telehealth. Although there's some discrepancy over some people feel telehealth can also refer to treatments that don't involve the therapist in real time. But whenever you see telemental health, that's referring to real-time treatment. There's been lots of research on telemental health, and the research has been very promising. There's been research comparing telemental health to treatment as usual, telemental health to waitlist. And in recent years, we're seeing telemental health compared to face-to-face treatment, which is perhaps the most rigorous or most conservative way to test does telemental health work. I'm going to present an example from my group's research on telemental health, where we're talking about real-time therapist-delivered treatment using video conferencing. This is internet-delivered parent-child interaction therapy, or IPCIT. Some of you may be familiar with PCIT. This is, here we're often traditionally talking about kids with behavior problems, conduct disorder, oppositional defiant disorder. These are kids whose parents have lost control of their house. Their kids often have rages and meltdowns, but they're still within that age where they can be scooped up under their arms and taken to a timeout room. The literature on PCIT is very positive. It's important to just for those of you in the adult literature and adult providers, PCIT is a behavioral parenting intervention. And there's a large family of behavioral parenting interventions that collectively are doing very similar things. They're very focused on maximizing consistency, predictability, and follow through in the home, helping parents learn how to have let their child lead interactions, having warmer, more positive and mutually reinforcing interactions with their kid, and then also learning effective discipline strategies and how to navigate difficult noncompliance and behavioral problems. There's a whole range, a whole family of these programs, and PCIT is one of those programs. What distinguishes PCIT from the other programs and what's always been very appealing to me is that in standard in-clinic PCIT, the therapist is not in the same room for the majority of treatment as the family. So here you can see this would be sort of a traditional PCIT session. The therapist for the majority of session is behind a one-way mirror. And the goal is for things to be as naturalistic as possible. The family comes into the playroom. It's a playroom with an observation room. And what you can't see in this picture is that the parent has a earpiece from a walkie-talkie, and the therapist behind the one-way mirror is providing live coaching to the parent through the one-way mirror. So some important features are the therapist is separated from the family, the parent is getting live coaching in the moment, and the child can't hear the therapist. So we're not out parenting the parent. We're putting the parents on the front lines, and we're trying to create as naturalistic a scenario as possible to intervene directly during parent-child interactions. So that's standard in-clinic PCIT. When we were developing, early on when we were developing some of the internet-delivered treatment options, we were particularly interested in PCIT because our thinking was that PCIT may be particularly amenable to a video conferencing format because the therapist is not supposed to be in the same room as the family. So decades ago, when Sheila Iberg and Cheryl McNeil were developing PCIT, decades before there was an internet widely available, they separated the therapist from the family on purpose. They separated the therapist from the family in order to foster a more naturalistic environment in which the idea is that gains could be more ecologically valid. So by separating the family already as part of the treatment, that was very exciting to us as an opportunity for testing the possibilities of technology. So for IPCIT, so instead of that behind the one-way mirror in IPCIT, we have the therapist at our clinic and the family's in their home, and through a webcam, and the parents wear a Bluetooth earpiece, and the therapist provides live coaching directly in the moment during family interactions at home. So here's a screenshot at the bottom. You can see therapist is in the lower right corner. The family can turn off so that the therapist doesn't have, so that isn't distracting to the child, so that they don't see anything on their screen. Oftentimes with PCIT, we're working with young kids. Many of them are so young they either don't know or forget quickly that the therapist is on the on the video call. So here's a screenshot of what it could look like. Here's another screenshot for those of you who know PCIT. This room, if I were in a room with all of you, I'd be asking questions like, what do you notice about this room that's different from standard PCIT room? When I present to PCIT International, people start cringing a little bit. There's a TV there, there's windows, there's so many breakable things. This is so many opportunities for disaster. But the truth is that when families come to us, we coach them in the sterile playroom where, with the one-way mirror is unbreakable, and there's all soft toys in there and everything. But then they go home and they break things. That's why they're coming in for treatment. So occasionally kids do break things in their house, but I've never had parents get upset with the provider because that's exactly why they're coming for treatment. This is not new to them that the child might break things. Here's an example. Hopefully this video will work, and the moderators can let me know if it's not working. Here, this video is from, I think, over 10 years old. So something you'll notice is the mom's earpiece. Now we have these nice, neat little Bluetooth earpieces. This looks like she's flying a helicopter or something, but you'll get an idea. The therapist is in the lower right. And with PCIT, for those of you who don't know, the parents are interacting, and the therapist, who in this video will be the male voice, jumps in and out saying, great, labeled praise, nice describing your child, and they are selectively attending to what the parent's doing, and praising the skills, and intervening in sort of quick coaching statements without talking over the child or the parent.
All right, so we're going to coach CDI for a few minutes. So remember to use all your CDI skills. I see you're settling in really nicely.
The green one. Such a tall tower.
Great, in your description. I love how focused you are on her play.
Oh, the chocolate for Rapunzel.
Great reflection.
Leah likes Rapunzel too.
Great reflection. Really nice job reflecting that back.
Oh, okay. So she was your friend. Not anymore. Okay.
You're doing a beautiful job following her lead.
If somebody has straight hair, you don't have friends. Then if they have straight hair, then they're your best friend. Yeah. Oh,
great reflection.
That's a good.
So in the interest of time, I'll stop it there. But you can see, of course, in this video, the child's pretty well behaved, very well behaved, and it's very powerful for a parent when a child's out of control or seemingly out of control, having a tantrum, and we're teaching the parent how to actively ignore that tantrum, and to have in their other ear the therapist saying, you're doing a great job ignoring that tantrum. She's doing everything she can to get your attention. And so parents find it really useful. And oftentimes when I'm with my kids, I wish I had a live coach right there as well. When we did a case series, then we did and got promising results, a lot of positive feasibility and satisfaction data. So then we did an RCT evaluating IPCIT, and we wanted to see how it measured up relative to clinic-based PCIT, so the standard PCIT. So families in this first pilot study were randomly assigned to either get IPCIT, where we did PCIT over the internet, delivering directly to their home, or standard PCIT, where they would come to us in the clinic. One fact of this design, one consequence was people had to be within enough distance to get to the clinic. We couldn't treat the entire state of Florida because if they were randomized to clinic-based PCIT, then of course they wouldn't be eligible. So we had a range that people had to be within for eligibility. So on the one hand, this really helped for internal validity to be able to look at what's the equivalency or differences between IPCIT and clinic PCIT. But just keep in mind, there are consequences of the selection method that we're not talking about rural families here. We're talking about families that are within a certain range of Boston or Miami. I started the study when I was up in Boston. So our thinking here was twofold, or our hopes were twofold. One was that this could prove to be a promising format for overcoming barriers to effective parent intervention. And also expanding the ecological validity of treatment by treating families in their natural setting. So as I was discussing before, working with families directly in the playrooms where they're having problems. I work with so many families in PCIT in the clinic, and they say, I don't know why he's being such an angel here. He's I promise he's a terror, and I say I believe them. So to a certain extent, we're seeing that more. And so coaching can be a little messier, but it's also in the very scenarios where these problems are most impairing. So as Danielle Cornacchio in your department, who is one of our lead therapists on the study, will tell you, as the study was happening, I was curious, how's it going to fare? And I was setting up, I just wanted to to tie PCIT, but then I was thinking, well, let's say it's 75% as effective. That's still great, because 75% a better response, than nothing if people are living in areas where they don't have clinic-based PCIT. And then in my more neurotic nights, I'd say, well, maybe 50% is good too, right? 50% is better than nothing in their area. And so I was wondering how low I could go. Anyway, so here are the outcomes of this first pilot study. We found very good outcomes in orange or red or whatever color it is on your screen. That is IPCIT, and then the bluish teal, whatever color it is on your screen, is clinic-based PCIT. And on the left, you see the post percentages, and on the right, you see the response rates at 6-month follow-up. So these differences here are not significant, but you see roughly 80 to 86% at post, regardless of intervention format, were rated as responders by independent evaluators. This is on the CGI, Clinical Global Impressions Improvement Scale. So this is if they got a 1 or a 2, for those of you who know the CGI. And then at follow-up, we saw similar gains as well. And then we looked at an extra conservative estimate of outcome. We looked at what's called excellent responders, which is on the CGI if they have a 1. If the independent evaluator, who doesn't know what condition they're in, rates the child as 1, very much improved, after doing a diagnostic interview and structured observations. And here we found a significant difference. We found that IPCIT had a 50% excellent responder rate. So again, this is versus 17% or 18% for the clinic-based PCIT group. So this is a more clinically significant, if you will, measure of outcome. We have independent evaluators who do a diagnostic interview, they do structured observations, and they don't know whether a family received their treatment in the clinic or over the internet. And we saw a significant, much higher response rate of excellent responders in the internet condition relative to the clinic PCIT condition. By the way, I didn't mention this, but same therapists across the 2 conditions. Same therapists, same supervision groups, everything. We see the ECB intensity, that's a behavior problems measure. The 2 conditions, we see nice reductions in behavior problems across mid-treatment, post-treatment, and follow-up. No significant differences between the 2 conditions. Also, physical punishment in these families went down, and comparably, we don't see any difference in slope there. In addition to the questionnaire data and the independent evaluator data, we also looked at perceived barriers to care. So we asked families on the Kasdan's measure of, I forget the name off the top of my head, but it's a barriers to care measure. And we saw, not surprisingly, that IPCIT, the internet condition, families reported significantly fewer barriers to care than families who were receiving clinic PCIT. So not only was it improving child and family outcomes, including physical punishment, and not only was it actually showing a significantly greater rate of excellent responders than clinic-based PCIT, we also saw that families themselves were perceiving fewer barriers to this treatment format. So we're building on this now. We've been doing IPCIT for kids with developmental delay. This is a larger study. This one's 150 kids, and we're done all of the treatment now. This is treatment, IPCIT versus treatment as usual, as kids are exiting out of early intervention. These are all 3-year-old kids with developmental delay. And we were interested in seeing how this performs, and this is a lower income, more ethnically and racially and economically diverse sample. So originally, we were calling this parental direction over the internet for developmentally delayed youth. Sort of describes what it was, and had this nice acronym, PDIDY. Also in Miami, I believe he has a house on Miami Beach. So we're thinking maybe, reach out, get some donor money if we name it after him. But also we thought this would undermine the seriousness with which people would treat the trial. So we're calling it the ACCESS study, Advancing Child Competencies by Extending Supported Services. So our long-term follow-up, we're finishing them up right now, and with the obstacles of the COVID situation, of course, but we should have the results of this study pretty soon. We've been doing telemental health trials across a range of child problems, anxiety, OCD, ADHD, and the results are pretty comparable, and they're also very comparable with what others are finding in the literature with adult populations. It seems that you don't get this dip that people had been concerned about when you do treatment over the internet. There's among therapists, there's often this concern that it's interfering with the process of treatment, the therapeutic process variables, relationship therapeutic alliance. What we actually find, I wrote we had a paper recently where we talked about the idea of perhaps some sort of augmented empathy. When a patient is in your office, they're learning about the context of your professional life. They're hearing, they feel what the temperature is like in the room at your office. They hear how busy, the sirens might be outside of your office. They see, what type of mood people seem to be in the hallways of your office. And they see how your furniture is in your office and what life's like in your office. When we do telemental health care and we're live coaching families directly in their home, we're hearing the sirens in their neighborhoods. We're hearing the sibling who's 1 year old and screaming and crying the whole time, the dog barking, the one parent not helping at all. We're seeing families in stress in their natural environments. And although it can be more distracting and can be sometimes more difficult to conduct these sessions that way, we're also getting a better sample of the context of their lives, and we're seeing things in their lives better. So I would argue that it's what you lose, you also gain in contextual information that individuals don't necessarily just report or have awareness of when they come into our offices and tell us about their lives. Of course, there are a number of new obstacles once we overcome old obstacles. The issues of licensure and jurisdiction. Licensure tends to be state-bound. So just because you can technically reach someone doesn't mean you have practice jurisdiction to work with them. There's minimum but growing consensus guidelines. There's questions about treating families in the home setting in what's called a quote-unquote unsupervised setting. Some high-risk patients would not be appropriate for telemental health. If you're working with a family and they're 7 hours away, and someone, if let's say it's a family with a maltreatment history, and a discipline strategy gets out of hand and you're 7 hours away, or if someone wants to hurt themselves. So these are things to really think through seriously. Billing and payer issues are, of course, important. Recent federal and state guidelines in light of the pandemic there have been some very rapid transformations. It's not sure if they're permanent or temporary, but right now a lot of the issues around billing and practice jurisdiction and security are not relevant for this period with regards to federal and state regulations and billing. Tech usage, tech literacy issues, of course. And then another really critical area is cross-cultural issues. Just because you can reach new communities doesn't mean that you have developed competency or to work with new populations. So a classic example in Oklahoma, they did a lot of telemedicine work with the American Indian population. And so they were able to reach this new population, but they realized very early on that most of their therapists were not equipped to work in culturally responsive manners. So the issues of cross-cultural practice is highlighted when we're using technology to reach new communities. In the interest of time, I'm going to skip a little bit on standalone treatments, mostly because they often don't work in the absence with no therapist involvement. This is showing that there's a significant rise in, this is where most of the action is in the literature. People are developing standalone no therapist involvement interventions, but many of them don't penetrate the marketplace, and then those that are on the marketplace are not necessarily effective. In our group, we did a study looking at apps for child anxiety, and we weren't interested in doing one of these reviews where you summarize the clinical trials in the literature. We wanted to go to the consumer marketplaces, the iTunes, Google Play stores, and see what apps come up when you're searching for child anxiety apps. And then we coded them. We were interested in, do these pass the test that Phil Kendall and John Passantini and, everyone would say that's evidence-based treatment for child anxiety. So, we coded them for psychoeducation, self-monitoring, cognitions, problem-solving, contingency management, fear hierarchies, exposures. And we knew it was going to be bad, but we didn't know it was going to be this bad. The apps that are marketed for child anxiety that are actually on the marketplace, not things that are developed in academia, but this is sort of what's in industry and on the marketplace. Only a quarter of them have exposures. Only 2% have fear hierarchies. Only 1 in 5 are focusing on cognition. So there's a real concern about quality. And then on top of that, in depression and anxiety, this is Akash Wasil recently did some interesting work that's in the American Journal of Psychiatry, where there's 10,000 downloads a month, but 4 apps account for 90% of this traffic. So regardless of how many apps are out there, there's really only a small handful of apps that people are using, Calm and Headspace accounting for most of that traffic. So what treatment's finding is when we're talking about asynchronous care using technology for largely self-administered care, standalone no therapist involvement, there's poor quality on the marketplace. Not enough people are using they're not using many of them, and there's a need for what David Moore calls supportive accountability. It doesn't need to be a therapist with formal training to deliver the treatment, but someone to check in once a week or once every other week. Do you have any questions? Are there, what are your plans for doing the modules this week? That little bit of what he calls supportive accountability makes an enormous difference. Without that, I mean, my phone's full of, hundreds of apps that seem like a good idea to spend $2.99 on at the time, and I've never opened them since. And mental health apps are just the same. So when we look at these minimal therapist involvement digital interventions, this is where I think there's a lot of excitement growing. This introduces workforce efficiencies. There's strong and growing support for these models. This model of digital therapeutics, which is on the rise now, is where you actually have a prescription for a digital therapeutic, and it has to be overseen by a provider, and now industry's rushing in to get FDA approval for these, and these apps and the provider's time are covered by, for the provider's time of asynchronous interactions are covered by Medicaid and other insurance programs. So this is sort of the wave of the future. But when we look ahead, the most exciting work is looking at the evolving role of technology. And the first wave was all, okay, this is what works in the office. Let's see if we can replicate it with technology. But there's a limit on that if that's the frame you're thinking. And the new model is really thinking, what new can we do with technology that we can never do in the clinic? And this is where sensors and wearables and implantables are coming into play. We live in the age of the quantified self, where people just for self-actualization have sort of self-knowledge through self-tracking, individualized, personalized informatics. And, these things are gamified. People, how many steps did you get? I got this many steps today. And the most exciting work on this front are what are called JEDIs, just-in-time adaptive interventions. And these are really, we're talking about micro supports, individualized treatments whenever and wherever the person needs help. So sometimes they're called ecological momentary micro supports. So a classic example of a JEDI, just-in-time adaptive intervention, is where passive sensors are monitoring your physical activity the whole time. So I guess the traditional model of improving physical activity you go and you meet with a provider and you set goals for the week. I'm gonna, get on the elliptical 3 times this week. I'm gonna park far away. I'm gonna take these 30-minute walks, whatever. You set your goals, bring the sheet back the next week. How'd you do? Not so well. What got in the way? Let's make plans for next week. So what a Jedi does is instead it's continuously monitoring the individual through like a smart band or something, or some sort of wearable. And it's providing, and it's noting maybe if it's set for 30 minutes go and the person hasn't moved, it might say, get up and do 10 jumping jacks. Or if they're in their house, go up and get a glass of water, or take a walk around the block, or, whatever it is. But it's providing sort of micro support instead of making grand goals for 30 minutes of this, and it's just always keeping you moving. It's always prompting you to move. So it's called micro supports, but they're in the moment, exactly when the person, in the moment of greatest need. And they're sort of in situ, they're the greatest ecological validity, the person's going about their day. And here we're not, micro randomized trials, which Susan Murphy's group has done amazing work developing. It's a whole other methodology where people are re-randomized thousands of times across a month or two. That's a whole other talk. But the problem here so far is that we have more data than we know what to do with. We can monitor so much, but we don't know what's noise and what's signal. And of course, the sort of great race is on for wondering, can passive sensors detect psychological states? So our group's been developing some of this work and trying to see, and it's not clear whether, is this the future or is this science fiction? I think there's a lot of research projects out there doing really exciting work, and it's not clear yet what's going to be. I will, in the interest of time for questions, some concluding thoughts. Telemental health with synchronous care sometimes even outperform traditional clinic-based care, and we shouldn't be thinking of it as a sort of inferior version of the real thing. In some ways it can be better, and I think that the genie's out of the bottle now with the COVID pandemic and stay-at-home guidelines, and I think it's going to be hard to completely bring mental health care back on board, especially when hospitals realize how much they can save in space and all of that, and families finding things so convenient. I think telemental health care is going to be a major part of mental health care even after this pandemic's over. But it does introduce new obstacles, issues of licensure, privacy, security, risk, things we've talked about, cross-cultural issues. There's some support for mHealth, but here this is really, sort of the Wild West. There's just tons and tons of apps out there that that don't do anything, aren't based in any sort of support. And then the most widely available apps lack support, but then the really well thought through apps that are often developed in academia or in academia industry partnerships, they sort of only live in journals, and people, when they search for apps on the market, they haven't penetrated the marketplace. So the digital therapeutics model where these interventions are receiving FDA approval and prescribed by a provider, that's seeming where things are headed, and especially wearables and using machine learning and Jedis really are the new frontier. I think we want to be thinking about technology. There's lots of support, but there's also new barriers. It's not the answer for everyone. There's issues of technological literacy, technological access. Originally, I think the thinking with the people that were excited about technology-based treatments, the focus was mostly on this is going to be for everyone. I think it's not going to be for everyone, but we need to break out of the horse race mentality and think about moderators for whom technology-based approaches are indicated to expand the portfolio of options we have for patients, that some patients are going to need different models. And there's always going to be an important role for human therapists. So this is not about innovating ourselves out of jobs. It's going to be about being more efficient with the allocation of human therapist time, not replacing therapists, but rather augmenting therapists, creating efficiencies, and improving the data that therapists have to make their decision-making and treatment planning with. Also, just another point, technology changes fast, and we need to stay agile. Not too long ago, NIH invested tons of funding into developing evidence-based treatments into CD-ROMs. Now, no new competing devices have a disk drive for a CD-ROM. And so now, unless there's a fortune to convert these programs into online models, that's progress that's stalled out there. So we want to stay agile, focus less on what specific device and platform a program is, and think more about the role of the therapist and how you can engage. So I'll stop there. I'm excited to answer any questions. Thank you very much.
Thank you, Dr. Comer, for giving that talk. And everyone in the audience, feel free to submit some questions. We do have one question to start off with. Somebody had asked, given some info that survivors of catastrophe benefited from other survivors, is medical expertise the only benefit of tech? Or could mentors provide as much good as professionals, especially if these mentors were trained by professionals and potentially even paid less than professionals?
Okay. Yeah, I think there's always going to be a role for whether it's paraprofessionals, whether it's peer support, and we see that in all sorts of models, substance use. We see it in personality disorder treatment, and just informally as well. So I think that the question is, mentors are a great example too. The question is, are we talking about billable healthcare or not? And then if we are talking about billable healthcare, there are regulations and practice issues. But technology, this can be used, in any way that people would interact. And if there was a role for that before, and I agree, survivors of catastrophes, it's hard to fly right out to some place when something happens, but support groups, this is, it's a critical opportunity. We run groups sometimes and people are in all different places. It's, the screens look like a Brady Bunch screen, just like these Zoom calls sometimes. Mm-hmm. But people really connect. It's not like it was several years ago when video conferencing, dropped calls every minute and had glitches and things like that.
Okay, thank you. We have another question coming in. Just-in-time interventions seem really helpful for suicide risk, such as if a patient endorses suicidal ideation or predictors of SI like hopelessness or perceived burden. Can you think of any challenges or pitfalls with this type of just-in-time intervention for suicide risk in particular?
Yeah, I think, I believe Matt Knox doing some interesting work along these lines, looking at machine learning to try to predict who's at imminent risk. Obviously, that's, one of the great challenges that the field, to identify who's at most risk and who is at imminent risk. I guess the flip side is, I don't know how many of you remember a movie called Minority Report, where people would be arrested. I don't even remember the specifics, but there were these oracles or someone that could tell when someone was about to commit a heinous crime. So people would be arrested for a murder they were about to commit, but they themselves didn't even know they were going to commit that murder. So the caution is, can you arrest someone for something they haven't even done? And if you sort of take that cautionary tale into mental health, if someone's at imminent risk for suicide, can you hospitalize someone based on some machine learning algorithm? And I think these are some of the ethics that are going to have to be worked out going forward. It depends on how how significant the consequences of the Jedi is, right? So if it's you're going to get a labeled praise prompt in your ear, the ethics probably aren't too high. If the ethics are that you would be involuntarily hospitalized, there's going to be the flip side to it to really consider. So I don't think that the field has navigated these yet, but I think the audience member who asked the question, it's a really exciting opportunity here, and with lots of implications for patients' rights and things like that.
Yeah, oh, that's really interesting. We have another question. There's enormous enthusiasm regarding technology-enhanced intervention approaches. You've been a pioneer in this field. And what is your greatest disappointment? What would your warnings be to folks moving into this area, which is important since most of us have shifted to telehealth these days?
So I would say the greatest disappointment is that to date, the best research has been conducted with populations that already had access to care. And to date, the clinical especially now with the pandemic, the people benefiting from telehealth were the same people largely who already had access to care. So the hope, in addition to the fact that we might be treating families in their natural settings, and that's so useful and potentially even more effective, the hope is that we're trying to broaden the reach of care, and we don't as a field have evidence of that on a grand scale yet. We still see the same percentage, if not worse, of people with mental disorders not getting care. So telehealth has not moved that needle yet. I believe that telehealth is going to, now with the new regulations and the federal relaxing of HIPAA concerns related to the provider's liability, and with telehealth, we're going to see a lot more telehealth care. But I do think it's going to be, if current practices show where we're headed, it's going to be a lot of the same people doing telehealth as a luxury, as a convenience, as opposed to truly expanding the net of people we're treating. So I do think that would be something, if anyone's getting into this area, truly trying to understand how what are the new barriers to telehealth among we're proving that telehealth works with populations that didn't have a problem accessing brick and mortar treatment. So I think we really want to now make a push to understand telehealth with rigorous clinical trials in rural populations, in predominantly ethnic and racial minority populations, low income populations, and it's going to be more of a challenge, and it'll be important for the field to go at that challenge and do some good work there.
Absolutely. And then our last question before we wrap up, somebody had asked about your thoughts on Talkspace, which was recently mentioned in the New York Times, or other texting-based therapies. Are there any legitimate studies on these?
So I haven't seen any. There's a lot of enthusiasm, certainly among the people at Talkspace. It's an interesting model. It's definitely a disruptive model. I think that there's, my guess is that it's going to provide support for some people. Will it provide support for someone, will it provide sufficient support for someone with psychotic disorder or bipolar or at risk for suicide? I'm not sure. I think there's an idea of mental health wellness and sort of psychological enhancement maybe outside of billable healthcare models, but it's so new, and like I said, it's a disruptive model that might is it sort of getting at like there's some models that are like Uber for mental health, and maybe there's a role for getting a new therapist every session for some problems and getting some live coaching. It doesn't need to be the same person, but it introduces a lot of questions. So no, there isn't any large-scale trials. It's been largely an industry model without academic partnerships. But now that it's out there and they have lots of celebrity endorsements and things, people want to be studying text-based models. There's definitely a role for text-based support. Is it sufficient in the absence of psychotropic management and formal psychological treatment? I'm not sure yet.
Well, we're out of time, but I wanted to say thank you again for taking the time out to give us this presentation and for answering our questions. And thank you everyone on the line for joining us. Have a good rest of your day.
Thank you very much.
Right.